Hello, everyone, and welcome to the first ASPA-FLEX webinar of 2025. I'm Evangeline, the webinar lead for today's webinar, Special Considerations for Special Needs. When we care for children, we recognize that some with physical, cognitive, behavioral, or psychological challenges will require extra care, attention, preparation, and optimization to enable them to receive their medical care and treatment safely. In today's webinar, we will actually touch on the challenges of caring for children with challenging behavior, autism, cerebral palsy, and neuromuscular disease in the perioperative period. Before we start proper, I'd like to acknowledge my team comprising Dr. Ade Ramlan and Dr. Teddy Fabila, who are providing technical support for today's webinar. I also like to acknowledge Dr. Linda Arasio, our moderator, and our four speakers, without whom this webinar would not be possible. Okay, without further ado, let me just introduce our moderator, Dr. Linda Arasio from the Philippines. Dr. Linda is a respected pediatric anesthesiologist practicing at Cardinal Santos Medical Center at Metro Manila in the Philippines. And she's also been actively involved with the graduate medical training and education, particularly in simulation. She's also a strong patient safety advocate, chairing the Safety and Quality of Practice Committee at the World Federation of Societies of Anesthesiologists. Without further ado, please take it away, Erlinda.
Hello, everyone. Thank you, Evange, for that nice introduction. Okay, before we start, let me share with you a disclaimer. Please note that the information presented in this presentation is intended for educational purposes only and is not meant to be a substitute for professional medical advice, diagnosis, or treatment. For the Q&A session, now, if you want to ask me how you ask questions or share comments, you can send in your questions and comments via the Q&A section. Remember, the chat and raise hand functions are disabled. Our moderators will highlight your questions and will make sure that we will be able to give the questions to the appropriate speakers during the panel discussion. Some questions will be answered by text with the appropriate speakers in the Q&A section. Furthermore, we are going to have our poll, and now once a poll is launched, you will be prompted to answer the polling questions. You will have 30 seconds to respond and submit your answer. We will share the results soon after, and after the results is shared, you may close the poll so that you can see the slide shared by our speakers. Go ahead now. So you can now start the poll. Our first poll is our first question, repeated instructions by different people is beneficial to a child or individual with special needs. Just one choice. The results show that most of you have answered false to this question. Let's go on to the next question. Our next question will asking you to please choose the best correct answer. A, children with autism always require pre-medication with anxiolytics. B, a nonverbal autistic child cannot understand what is said. C, the use of guided imagery helps reduce stress during the induction of anesthesia. And D, children with autism have a high threshold of pain and therefore do not need analgesia. I missed the results. Oh, there they are. The results show that many have answered letter C. You'll find out later on what the real answers are. So let's go on to the next question. Our next case is, which of the following patients is at the highest risk of extubation failure? A 15-year-old girl with severe scoliosis and an FVC of 50%. B, a 15-year-old girl with spinal muscular atrophy and FVC of 45% and a peak cough of 300 liters per minute. C, a 15-year-old boy with Duchenne muscular dystrophy and an FVC of 50% and a peak cough flow of 150 liters per minute. Or D, an 11-year-old boy with Duchenne muscular dystrophy and FVC of 50% and moderate OSA, obstructive apnea hypopnea index of 7 per hour. The results show that most of you have answered letter D. Okay. Finally, last case is microaspiration a concern for children with cerebral palsy. Single choice only. Is it yes, a real possibility? No, not at all. Or is it always a possibility? That's hard. And our results show that most of you have answered letter A. Okay, so back to you, Evange.
Thank you very much, Linda. Well, thank you to you, our audience, for taking part in the poll questions. Remember your answers because we'll go through the questions at the end of all the talks when the correct answers will be revealed. So stay tuned. Okay, let me first introduce our first speaker of today's webinar. And she is Ms. Tanuja Nair, a senior principal child life therapist in private practice in Singapore. But until recently, she was actually practicing in the largest children's hospital in Singapore, that's KK Women's and Children's Hospital, where she has actually helped countless children and their families through the most challenging and darkest periods of their lives. Tanuja will be speaking on a topic, managing challenging behaviors in children and individuals with special needs in healthcare settings. So without further ado, I'm going to hand it over to you, Tanuja.
Hello, everyone. Thank you for tuning in to my presentation today on managing challenging behaviors in children and individuals with special needs in healthcare settings through the lens of a child life specialist. Through this presentation, I hope to be able to share some insights on the types and reasons behind some challenging behaviors and some behavior management strategies. My presentation will comprise of the following components, and I trust this will help in achieving the session objectives for today. Just a little introduction about myself. I am Tanuja and I'm a certified child life specialist. I have been working with children and families for about 23 years, and nearly 17 of those years were spent supporting children and families in a leading pediatric hospital in Singapore. Now, what is a child life specialist? As you can see on your screen right now, there are many definitions to it. But one way to summarize it is that we take the scary out of being in the hospital and medical settings. And a personal favorite of mine, we're like a game-changing rock star, where we try to ensure that the pediatric experience is a positive one. Let's dive in to understand a little more about child life services. The following diagram depicts the 5 main value drivers of child life services. In essence, child life services is a profession that looks at empowering children with effective coping through play, self-expression activities, and age-appropriate medical preparation and education. Child Life advocates for family-centered care where child life specialists work in partnerships with families, doctors, nurses, social workers, and other key stakeholders to meet the unique emotional, developmental, and cultural needs of each child and family. The role of a child life specialist in a healthcare setting includes providing emotional support to children and families facing medical challenges, empowering children with coping strategies so that they can manage stress and anxieties more effectively, and striving to enhance the child's healthcare experience by making it more positive and less stressful. Child life specialists have a strong background in child development and hold either a bachelor's or master's degree with an educational emphasis on human growth and development, thus helping them to address varied and important needs during the child's and family's healthcare experience. One of these concerns is that of addressing challenging behaviors in healthcare settings, which is the next section of this presentation. As a start, it is important in understanding the psychosocial dimensions of a child in the hospital. How much does he or she understand about being in the hospital? Is there parental support available? Does the child have any medical or developmental concerns? And does he or she have any past medical experience which may impede how he or she responds in this current admission? And lastly, but certainly not least, are there any cultural or religious background issues we need to be aware of, which might also affect how he or she understands and perceives the current experience in the hospital? It is important to note that generally, all children, when faced with an unfamiliar situation, will feel highly uncertain of what to expect. This high uncertainty leads them to feel powerless, thereby escalating their feelings of feeling threatened and distressed. When this happens, some of their senses may shut down or become highly charged, thereby affecting the way that they process information. The possibility of misunderstandings are high, and this cycle of being poorly informed and feeling highly distressed continues. In a chapter in the Disability Practice Handbook entitled Supporting People with Complex and Challenging Behavior, Hogan and Bigby explained how children and individuals with more severe levels of intellectual disability, neurological diagnosis such as autism, and those with sensory impairments are more predisposed to display challenging behaviors. Some of these challenging behaviors can be presented in the following forms: biting, shouting, hitting, extreme fussing, and meltdowns. In addition to an existing disability, diagnosis, or medical condition, there are also environmental triggers we need to be aware of which can further exacerbate challenging behaviors as such. Let's explore some of them now, alongside some suggested strategies to manage these challenging behaviors. Physical touches and medical procedures can present as a very big trigger for individuals with special needs. This alone can invoke fear, discomfort, and a whole series of self-preserving behaviors. To mitigate the stress associated with physical touch and medical procedures, preparation and education support can be extended. Pre-op visits and explanations can help in illustrating what is to be expected. Here are some examples of preparation and support in the form of videos and social stories which are readily available over the internet. I've included the links for some of these resources here on this slide for your easy reference. Additionally, to also address physical touch and medical procedure anxiety, being familiar with some behavior management techniques such as distraction, positive reinforcement, and routines can help in further mitigating hospital-induced anxiety. These can be in the form of visual reward charts where 1, 2, or 3 important behaviors or expectations are listed alongside the provision of a small token to help encourage children and individuals with special needs to display appropriate behaviors. On a side note, I've always also found it very helpful to consult with psychologist colleagues to check in and seek their inputs when there are more complex behavioral needs on hand to be addressed. Sensory overload is one of the biggest factors to bear in mind for children and individuals with special needs. Bright lights, multiple voices, Strong smells of medicine are all potent triggers which can lead to confusion and anxiety. To address auditory overload, minimize unnecessary stimuli as much as possible. Reduce the number of people speaking to the child or individual and use soft, quiet tones. When their eyes and brains are overstimulated, that can also give rise to more confusion and anxiety. Try reducing the brightness of lights and perhaps offer eye blinkers for those who need it. For those with tactile overload, some individuals may need some physical grounding to help them recalibrate. In these cases, the use of weighted blankets or sensory toys like bubbles, feathers, and stress balls may help. Seeking the support and inputs from occupational therapists can be most helpful in providing more targeted sensory calming solutions. Language and communication barriers are often overlooked when it comes to children and individuals with special needs. It is important to bear in mind that this vulnerable population may not communicate in the same way as you and I do, and this then gives rise to their feelings of frustration and anger when their wants and needs are not met or even understood. In such cases, it could help for us to remember that sometimes less is more. When a child or an individual with special needs is having a tough time, then there is a chance that he or she may have shut down and verbal processing is impaired. During such times, it's best to keep instructions and verbal directions to the bare minimum and instead turn to the use of visual supports in the form of perhaps visual cues such as emotional charts or calming strategy cards, and also to use transition objects to avoid frustration. Similarly, the words we use and the way we communicate has an impact on these vulnerable individuals. Some communication tips to bear in mind include adopting a more understanding and gentle approach. Provide reframing. Do not attack the child. For example, you could try saying, "It's okay to feel angry, but it's not okay to hurt others. It looks like you're having a tough time. I'm here to help you." Being upfront with expectations will also help. Use short, specific, and simple sentences such as, "Hands are not for hitting. Let's find another way for you to show me how you feel." Or, "It's important to use gentle touches when we are around our friends." Sometimes, by simply offering 1 to 2 reasonable choices, the child can regain a semblance of control, thereby alleviating their fear. Try offering a choice like, "You can sit here and take some deep breaths, or we can go for a walk." Let's try using words instead of actions to show how you're feeling. Or, "Would you rather squeeze a stress ball or take some deep breaths?" Instead of just saying no or to stop doing something, provide them with better redirection and try saying, "Let's try pulling on this slinky toy if you feel very upset or angry." Or, "Let's try using the punching pillow instead of hitting someone, or yourself for that matter." Equally important is to show them what is appropriate and offer them positive words of encouragement and affirmation too. You could say, "Thank you for using your words to tell me what you need or how you feel." Or, "I notice how you took deep breaths to calm yourself down. Well done." For more targeted communication strategies, do remember to reach out to your speech therapy colleagues too for their inputs. Building relationships with children through familiarity, trust, and appropriate communication promotes cooperation. Engage in open communication and work towards shared goals so as to get the family's buy-in and support. Remember, the family can be a helpful and effective healthcare ally in supporting children and individuals with special needs in the healthcare setting. Let's now explore a case study together to see how strategies which have been shared today can look like when called to action. Justin is 10 years old and has autism. He was recently admitted owing to severe constipation and he required surgery. As he entered the operating room, he became distressed, exhibiting signs of a meltdown, crying, screaming, and attempting to escape. His heightened anxiety stemmed from a sensory overload, being in an unfamiliar surrounding, and a fear of the anesthesia mask. Justin was so upset that he could not listen to anyone or follow any instructions. With little choice, the surgery had to be postponed. To help prepare Justin for his upcoming new surgery in 3 days' time, a multidisciplinary team of doctors, nurses, child life specialists, and the family came together to collaborate and support Justin so as to mitigate hospital trauma reactions. First up, visual supports and social stories were used. Prior to the procedure, the team read simple social stories explaining what would happen step by step using pictures and clear language. This helped Justin to anticipate the next step, making the experience and environment feel less overwhelming. Next, distraction techniques were utilized. A tablet with his favorite calming video was used during the induction process. Additionally, Justin was encouraged to bring along a comfort toy to provide a soothing and familiar stimulus. Only one person was given directions to Justin so as to minimize auditory overload and reduce confusion. As a result, Justin's focus shifted from the stressful hospital setting to the comforting sensory input from his video and comfort toy, thereby reducing his overall anxiety and eliciting better cooperation. Thirdly, gradual desensitization and choice offering options were provided. Instead of forcing the anesthesia mask on Justin immediately, the anesthetist allowed Justin to hold it first. Justin was also given a choice between wearing the mask himself or having Mummy help him with it instead. This seemingly simple option helped to restore some semblance of control for Justin. With these strategies implemented, Justin was more prepared this time round and he was able to complete his surgery successfully. There were still moments of tears and anxiety, and these were expected as it is still painful and uncomfortable for him. And note, crying is a form of coping, and Justin needed that outlet to express himself. However, with the incidence of hospital trauma now reduced with all the new preparation and support measures, the overall anxiety for Justin and his family and the healthcare team was significantly better. As learned from the case study and the preceding info slides, understanding the reasons behind challenging behaviors is important in helping us to pave the way for effective care. More often than not, there is a need to combine and modify varied strategies to elicit the best results. And by understanding challenges, implementing effective strategies, and collaborating with families, we can create a positive and supportive healthcare experience for all, including individuals and children with special needs, their family members, and for both you and I. Before we end, here are some useful resources for you to look up if you would like to learn more about managing challenging behaviors. The following is a reference list I have used for this presentation. We've now come to the end of my presentation. I hope you have found it helpful and insightful. On that note, I thank you for your attention. Thank you.
Thank you for that insightful talk, Tanuja. So before we go any further, before you ask your questions, let's move on to our next speaker, Dr. Evangeline Lim Wally, who is the head and senior consultant at the Department of Paediatric Anesthesia, KK Women's and Children's Hospital, Singapore, and an adjunct assistant professor at Duke NUS Medical School, Singapore, with interest in pediatric cardiac anesthesia, children with special needs, and medical education. The spotlight is now on you, Evange.
Thank you very much for the introduction and hello everyone. In this talk, we will be discussing how we can make the peri-anesthetic management of children with autism spectrum disorder a better one. In the next 15 to 20 minutes, we will cover the characteristics of autism spectrum disorder, pre-anesthetic assessment and preparation for induction of anesthesia, intra-procedural anesthetic considerations, and lastly, post-procedural care. So what is autism spectrum disorder? It is a neurodevelopmental disorder that typically manifests by age 3 with varying severity and symptoms that impact how a person experiences the world and interacts with others socially. It may occur as part of a syndrome like Fragile X or Angelman syndrome, or occur in isolation. Frequently, there is a genetic basis to it. Individuals with autism have challenges with social skills and difficulties with communication and expressing their feelings and needs, even if they understand what is being said to them. They may also have limited or restricted interest, prefer routines with this change, and engage in repetitive behavior, which may be a coping mechanism to help them deal with uncertainty. It is also important to be aware that they may have altered responses to light, sound, touch, temperature, and pain. When they experience anxiety or frustration, they may exhibit aggressive behavior and self-harm. Conversely, by understanding their needs and reducing uncertainty, we may be able to avoid triggers of maladaptive behavior and harness their coping skills to make their anesthetic experience a more positive one. Functionally, there are 3 levels of severity. By noting the severity of the condition impacting the daily life of the child, we can tailor our peri-anesthetic management to ensure the child receives the required level of support. Children with autism tend to have a high incidence of physical and mental health comorbidities such as epilepsy, obesity, hypertension, immune dysfunction, motor anomalies, gastrointestinal disorders, sleep disorders, intellectual disabilities, and psychiatric disorders including attention deficit hyperactivity disorder, anxiety, depression, self-harm, and suicide. Not surprisingly, children with autism are more likely to require anesthetic care for procedures compared to those without. The SPACE framework prompts us to consider their physical, processing, and emotional needs when caring for them. Why do we need to try and make the hospital experience a better one for children with autism? With a higher incidence of comorbidities, there is an increased likelihood they will require medical attention and present to our healthcare systems. However, healthcare settings are stressful even for neurotypical children, but more children with autism. As a consequence, they frequently become agitated, and this may be aggravated, particularly if they are feeling physically unwell. Adverse prior healthcare experience, such as the excessive use of restraints or the presence of overwhelming stresses in the hospital processes and environment, may result in avoidance of the healthcare system, resulting in atypical or late presentation. This in turn increases the risk of hospitalization, length of hospital stay, and intensive care unit admission. Previous studies have suggested that autistic individuals are 3 times more likely to be admitted from the emergency department and twice more likely to die. Besides advanced disease, this may be contributed in part by communication challenges, poor care coordination, and medication errors arising from the complexity of care frequently required. In another study, the length of hospital stay was on average 2 days longer for children with autism. We also need to be mindful that the family will be under stress during this time period from the disruption of normal routines, chronic caregiving, as well as financial burdens. It is therefore important that as anesthetists, we try and make the healthcare setting encounter as brief and positive as possible. So what are our goals? These include understanding the child's needs to provide individualized care with empathy in partnership with the primary caregiver and the patient if possible, be accepting of their needs and flexible where possible, reduce anxiety by introducing predictability through adequate preparation and keeping to the same medical staff for consistency as far as possible, minimize stresses in the hospital such as the taking of parameters, requirement to change clothes, waiting, intravenous cannulation, or loud, noisy, crowded environments, avoid hospital admission if possible, and when not possible, then minimize the duration of stay, promote return to normal function and routines as soon as possible, communicate using the child's preferred mode of communication, and reduce hospital phobia by providing a safe and positive hospital experience. To achieve our goal of improving the peri-anesthetic experience, teamwork is essential. We need to map out the patient's journey to identify intervention points and engage with stakeholders who include our colleagues like the nurses, proceduralists, listening room staff, allied health staff, caregivers, and the patient to streamline care processes, create suitable resources to prepare the child for anesthesia and procedure, and be able to send the child home as soon as possible. If staff are trained to be more aware of the special needs of children with autism, they are more likely to be patient, mindful, and flexible when caring for them. For example, they will know to speak to these children simply, calmly, and clearly. Good communication within the healthcare team is important to ensure all are on the same page with regards to the medical care of the child. Team huddles and documentation within the medical records inform staff of the child's characteristics, trigger points, coping strategies, and the coordinated medical plan, especially if more than one procedure is to be performed under general anesthesia or sedation. Being able to identify a child with autism before first encounter is helpful so that the staff can be signposted to look into and understand the child's needs before interacting with the child, thereby avoiding potential trigger points that may upset the child unnecessarily and result in meltdowns and other maladaptive behavior. In KK Hospital, we use a dolphin sticker to help us identify children with special needs. We'll talk in greater detail about possible modification of the physical environment and resources later. Let us start first with pre-anesthetic assessment and preparation. We need a minimum of 1 week before the planned procedure to get to know the child and begin preparation. The child may be assessed in person if physical examination is required, or virtually via video conferencing or a phone call. We want to assess the anesthetic risk and optimize any comorbidities. If physical examination is required, we should ask the caregiver how best to do this before touching the child. We also want to know how the child normally communicates, including how the child communicates pain. It is also appropriate after assessment to confirm that the child is suitable for day procedure, same-day admission, or requires admission the day before for further preparation. After understanding the child's needs better, we should work out an anesthetic plan with the caregiver. Reviewing previous anesthetic records for details such as the need for pre-medication or the child's response to anesthetic technique will also be helpful in preparing for this future anesthetic encounter. Lastly, work with the proceduralist to determine things like the timing of the procedure after taking into consideration the child's preferences, as well as the need for investigations and other procedures to be done at the same setting. An individualized care plan is co-created with the caregiver and, where possible, the patient. And this takes into consideration the child's needs, routine, and coping mechanisms. We need to be aware, however, that these may change as the child grows. The plan includes fasting, knowing what sort of chronic medication the child may be on, which have the potential for interaction with our anesthetic drugs, building up coping mechanisms, and then engaging the help of a child life specialist if available. We should also discuss the need for pre-medication with the patient and caregiver, and this need may depend on the severity of autism. Other points for discussion may include the use of restraints as well as the recovery plan, including details like whether the intravenous cannula should be removed before the child is fully awake. In a study by Joe et al., 60% of their patients followed their individualized care plan without need for pre-medication, and 98% of caregivers who responded to the post-operative survey voiced satisfaction with the scheme. Next, let us discuss resources. To aid medical staff with understanding the child, a hospital passport is important, and this should be filled by the caregiver. A physical copy may allow for easier, more rapid navigation through the hospital if processes are put in place. Our passport at KK Hospital asks for details on how the child communicates, the child's sensory challenges, signs shown by the patient before going to full meltdown, coping mechanisms, and special interests or preferences. Knowing how the child normally takes medication can be helpful in determining the child's preferred route and form of administration of medication, including anxiolytics and analgesia. We also ask for information to gain the child's cooperation with physical environment and for behaviors that we need to look out for, which could be of safety concerns, such as the tendency for hitting, biting, or self-injury. We also need to provide caregivers with educational resources such as videos and social stories to help familiarize the child with the hospital environment and processes such as mass induction. Social stories, as mentioned by Tanuja, are short picture stories of procedures with stepwise narration, so the child knows what to expect each step of the way. This helps reduce anxiety arising from fear of the unknown. A child life specialist can be a valuable resource to help the child process and cope with the demands of medical procedures. At KK Hospital, we also give out a toolkit which includes a face mask, and we ask the caregiver to practice putting the mask on the child's face for increasing periods of time each day to familiarize the child with the concept of mask induction. Desensitization is a useful technique based on applied behavior analysis that can be practiced at home or at school to help the child get used to a process, such as mask induction or intranasal administration of pre-medication. Sufficient time, however, is required to prepare the child this way. I've personally seen success with this technique, even with nonverbal autistic children who accept the mask applied to their face without issue, resulting with mask induction ending up being a much smoother process even without the use of pre-medication. Environment modification can help a child with sensory challenges cope better. This may include the use of sensory toys, a quiet or sensory room, as seen in this picture of a sensory preoperative room in Dayton Children's Hospital in Ohio, the United States. Gliders are helpful for children who use swinging motions as their calming mechanism. We can attempt to reduce anxiety in children with autism using pharmacological and non-pharmacological means. A variety of anxiolytics as shown may be administered via different routes. Not all children, however, require pre-medication with anxiolytics, and the severity of autism may determine its use. For example, many with severity level 1 autism do not need anxiolytics. But those with severity level 2 or 3 frequently do, and they may require less conventional pre-medication such as intramuscular ketamine sedation. Non-pharmacological means to reduce anxiety may include reducing uncertainty by providing information and using timelines to increase predictability. Having consistent staff and familiar faces also helps reduce anxiety. It is also useful to tap on the child's normal coping mechanisms, such as the use of devices, games, videos, pressure application, or breathing exercises. I want to highlight specifically that the use of guided imagery does not tend to work well for children with autism due to their limited capacity for imagination. It always helps to give them clear, direct instructions. Depending on the procedure, general anesthesia or sedation may be employed via a variety of ways. The techniques and drugs used are not necessarily different from those used in non-autistic children. I just want to highlight in particular the usefulness of dexmedetomidine as both an anxiolytic as well as a sedating agent. Other intraprocedural anesthetic considerations include being aware that the requirements for hypnosis may be less for those with intellectual disability, keeping things simple to ensure a rapid, smooth recovery, avoiding pre-medication if not required, paying attention to the environment during induction, in particular the lighting, sound, as well as the number of people in the room, minimizing unnecessary conversation, adopting a hands-off approach, getting instead the caregiver to help with things like applying the mask on the child's face or holding the child. We want to avoid nitrous oxide in children with autism who also have mitochondrial disease and methyl tetrahydrofolate reductase deficiency because nitrous oxide will result in increase in homocysteine levels and overall oxidative stress, which might then lead to post-procedural complications. We also want to ensure good hydration, nausea, vomiting prophylaxis, ensure good analgesia, normal glucose, temperature, acid-base balance, avoid hypoxia, and observe the usual infection preventive precautions. In autistic patients, with mitochondrial disease, it is prudent to avoid Ringer's lactate as well as prolonged propofol infusions. Okay, we also need to be aware that children with autism may be on anti-epileptics as well as medication to help control behavior and moods, and these may interact with our anesthetic agents, resulting in hemodynamic disturbances and altered requirements of anesthetic agents. Post-procedure, we need to be aware that delayed awakening may be seen in those on anti-epileptics and intellectual disabilities. It is ideal to allow recovery in quiet environment with minimal monitoring, facilitate early reunion with their caregiver, and be flexible with regards to discharge criteria, for example, not insisting that the child takes food or drink before going home, but instead choosing to follow up with a phone call after the child has been discharged. We also need to watch out for complications which may be increased in children with autism and other disabilities, such as airway obstruction, hypotension, and nausea and vomiting. Let's talk about pain management. Individuals with autism may perceive and process pain differently, which may make pain management in these children challenging. These children may not react to noxious stimuli in the usual manner as neurotypical individuals, exhibiting few signs of distress or apparent indifference. However, this apparent high tolerance to pain does not mean that the individual is not experiencing any pain and therefore does not require any painkillers. Pain management challenges may be compounded by difficulties with communication, cognitive ability, or the presence of comorbidities. Hyporesponse to pain may result in more extensive, unrecognized, or late presentation of injuries and disease pathology. On the other hand, some autistic individuals may exhibit hypersensitivity to pain by having exaggerated responses to minor injury, which, if not well managed, may lead to anxiety and avoidance behavior in the future. In their pain management, we also need to consider offering pain relief methods that align with the individual sensory preferences, such as the use of weighted blankets, music therapy, acupressure, aromatherapy, and we also want to consider using distraction therapy as well. If we are going to use pharmacological analgesics, then implementing routines using cognitive behavioral therapy, visual aids can actually help the child cooperate with the administration of analgesia. In summary, better anesthetic and hospital experience can result in better health and medical outcomes in the child with autism. Understanding the autistic child's needs and preparation is key. Recognize the caregiver as our expert partner in care. Having an individualized anesthetic plan is feasible and beneficial. Consider environmental modifications to help reduce sensory overload. Trained staff and team communication are important for safer, coordinated medical care. Provide good anesthetic care to facilitate return to normal routines and function as soon as possible. And lastly, I hope you agree with me that better peri-anesthetic management of the child with autism is possible. With that, thank you very much for your kind attention, and I'll be happy to take any questions at the end of today's session.
Thank you for sharing your expertise and your passion for the subject, Evange. And as you said, she said, we will take questions later on. Our next speaker is Professor Vrushali Pandit, who is a consultant anesthesiologist specializing in pediatric and regional anesthesia, affiliated with multiple hospitals in India. She holds several leadership positions, primarily in the WFSA and the ASPA as the president-elect of the Asian Society of Pediatric Anesthesiologists. You may now have the floor, Vrushali.
Glad you are here. Let us look at a day of an adolescent who is a patient of cerebral palsy, they do have their own personalities and life. Getting ready to go to college, they do have normal intelligence. So the intelligence can range from mental retardation to super intelligence. They have their wit, they have their personality, as I said. We're soon going to see it. They have their individuality. So this is about a day in a child's life, and they can be in various stages of life. Having said that, let's look at what we as anesthesiologists contribute to their existence. So the paradigm is definition of cerebral palsy, etiology, their types, different surgical procedures, issues related to anesthesia, pre-op visit and preparation, pre-medications, inductions, role of regional anesthesia, very biased towards this, and post-operative pain management, and we'll see what is really important here. So this is one article that we picked up because we thought that it's very less in literature when it comes to cerebral palsy. There's a big dearth, and we picked up 400 patients that we had done as a cohort study, and we looked into the various aspects, primary objective being the pain management in the post-operative period. So definition of cerebral palsy is a spectrum of permanent non-progressive neurodevelopmental disorders of motor and postural development caused by injury to fetal brain and brain until 3 years of life. The prevalence is quite a bit, 1.5 to 2.5 per life birth, so it's more than what we thought it was. Etiology is damage to motor control centers of developing brain. So types could be many. It could be hypertonic, spastic monoplasia, hemiplegia, diplasia, triplasia, quadriplegia. They could be very loose. They could be hypotonic, and they can have ataxias. Mental retardation, one end of the stick is normal intelligence and the other end of the stick is severe mental retardation. So in the range. Procedures done on cerebral palsy, the orthopedic surgeries is especially aimed for improving motor functions and re-establishing the balance of muscle forces. The soft tissue releases, the osteotomies all aid towards it. Even the Botox and the repeated plasters aid that. Gastrostomy to improve the nutrition. Esophageal dilatation because they have refluxes, and reflux can cause esophagitis, giving to constriction bands, and then dental surgeries. That's also a huge chunk of CP surgeries. So issues related to anesthesia, we just discussed reflux. And then esophageal dysmotility that actually can give us issues while we are inducing, and then the aspiration and lung issues that they have. Lower esophageal sphincter dysfunction, drooling, inability to swallow, so malnutrition, anemia, feeds may be going on. Respiratory tract system, and here it's paving way to pulmonary aspirations, the esophageal reflux and all of it. Recurrent respiratory infections and chronic lung disease is common. CNS, they could be on many agents such as the antiepileptics, the poor head control that they have, the mental retardation, hearing and speech problems might lead to difficult communication, not just before but even after the operation for the pain management aspect and behavioral issues. So multidisciplinary approach is here to go for when we have to deal with cerebral palsy children. That's because we are going to need a physiotherapist, we are going to need a neurologist, we are going to need, of course, an orthopedic surgeon or a dental surgeon or a pediatric surgeon, the PICU, if at all the ASA grading goes 2 and beyond. Any child with cerebral palsy is ASA 2+. Well, so assessment during the pre-op is, apart from understanding what medications they are on, and something that is very, very obvious otherwise, they are special, their needs are special, mind you. We need to pick up that primary caretaker, and they can be very anxious due to repeated exposures, including their primary caretaker, is what I'm trying to tell you. So to know the family and the child, clear their doubts. If they say that there's a night awakening repeated, that's reflux. Strongest advocate, as I said, is the primary caretaker. It may not be the mom always, it may be the grandmother, it may be the nanny. So the strongest advocate is that primary caretaker, and they could be a bit aggressive, or they could be, that's all due to the previous experiences and the guilt that they might harbor, the frustration, the anger of not being able to do what they would have otherwise wanting to. So when pre-op optimize, take control of seizures, continue the medications, bronchodilators and antibiotics for optimization if required, physiotherapy, anxiety and poor communication skills, yes, pre-medication is even more important. So medications such as gabapentins and baclofenac and benzodiazepines must continue. Pre-medication is important. It could be oral if we have asked for investigations just one day before, may as well have that IV in place. In a spastic child, it's very difficult to take an IV, but if they're taking the trouble, then they may as well secure a Venflon. So yes, oral midazolam indeed is a boon. Antibiotics, bronchodilators could be continued and should be continued. Antacids, of course, if they help us. So inductions can be inhalations, it can be intravenous, the easiest way. Mind you, if we have a vein, we need to pre-medicate them, put them to sleep in front of the parents, because in the cold atmosphere of the operation theater, their spasticity gets exaggerated. Inhalational inductions, yes, issues with sevoflurane, they're not going to be very easily acceptable to it, and the movements are exaggerated, as I told you, and if they drool, that's even a bigger issue. However, this is one example that I would like to show you. So distract them. As the child grows, in fact, it becomes more and more difficult, but yes, you can distract them. Maintain a cool tone, have a person whom they know, even from the surgical team around them, because they have interacted them more often, and continue with their induction. You can see the half-hazard movements that are going on. So what the surgery is, if it's soft tissue, it might indicate that it's not that intensive in pain. If it is osteotomy, it goes without saying that it's pain intensive. However, in cerebral palsy children, they both should be looked at with the same intensity, because soft tissue release plaster is going to give them, after the block wears off, is going to give them pain sensation. That very pain sensation is going to trigger a spasm and more pain sensation. It's a vicious cycle that your continuous block needs to cut it off. Hence, I guess continuous blocks play a major role. May it be in upper extremity, may it be a lower extremity block, or may it be a continuous epidural block. So post-operative pain management really takes a very big chunk of cerebral palsy orthopedic surgeries, and that's where your entire understanding is called for. However, there is very little published literature. We have scores for cerebral palsy children, post-operative pain, but it's very cumbersome, and hence we depend upon certain things such as the primary caretaker. Number one, how has the child slept? How is the child eating? And the expressions, the groanings and the moanings, or the withdrawals, or those who are very vocal, there would be some surprisingly vocal, they will tell you. Probably you might not understand what they're speaking. Again, the primary caretaker tells you what they mean. So in summary, the evaluation of sleep quality and quantity of feed may be helpful in assessing analgesia. Despite single shot and continuous regional anesthesia technique, I must confess, multimodal anesthesia regime still can give 15% of patients experiencing severe pain, but they did respond to treatment adjustments such as a bolus dose, escalation in the infusion rates, and escalations in other analgesics such as paracetamols or ibugesics, or even muscle relaxants that did the job for us. So role of primary caretaker is pivotal. Please understand before we conclude the slide. So understand them, communicate with them, and an untreated pain in a cerebral palsy child or in any child for that matter can go to chronic pain, especially in this population. Professor Chalkiadis has shown it very well, and other conditions can also get exaggerated. So this is a call for compassion, a tad more than what we would have anyways for others. Having said this, these are my thoughts on cerebral palsy anesthesia recipes, and it can be improvised even further. If there are any comments, suggestions, and questions, I would love to take them. Thank you so much.
Okay, thank you so much, Dr. Brushali, for basically sharing your thoughts on how we should actually care for children with cerebral palsy better. And I'm really glad that you kind of re-emphasize the need actually to partner with their caregivers, okay, because they are the strongest advocate actually as to what might be the best plan for these children. Okay, lastly, let me just introduce our final speaker for today, Dr. Aaron Saint-Laurent, who is an assistant professor and pediatric respirologist at Western University and the Children's Hospital London Health Service Centre in Ontario, Canada. I think you can well imagine and appreciate actually the time difference that he has. So we are really grateful that he will be sharing with us his expertise, okay, and tell us about prehabilitation and its role in children with neuromuscular disease who are actually scheduled for surgery. So without further ado, let's hear from Dr. Aaron.
Hello, my name is Dr. Aaron Saint-Laurent. I'm a pediatric respirologist at the University of Western Ontario, or Western University in Canada. I'd like to thank the ASPA-FLEX webinar organizers for inviting me to give this talk. Today I'll be speaking to you about prehabilitation, or specifically mitigating postoperative risk in patients with neuromuscular disease and complex neurologic disorders. I have no conflicts of interest to disclose on this topic. And the objectives of our talk today, first we'll be discussing the anticipated complications and the pathophysiology around them, as well as discussing who the at-risk populations are that we'll be covering. We'll be assessing risk in your patient. How do we do this? And this will include pulmonary function and assessment of gas exchange. And then finally, we will be talking about prehabilitation and mitigating risk, kind of how we do this in the preoperative sense, as well as the postoperative sense. So the primary reference that I'm using on this topic is a narrative review that I did on this topic with some of my colleagues and mentors called Respiratory Prehabilitation in Pediatric Anesthesia in Children with Muscular and Neurologic Disease. So if you're looking for more information, further references, or anything along those lines, you should be able to use this article, hopefully, to find them. So we'll start by kind of talking about what the predisposing pathophysiologies are in these populations. So the first kind of major problem that can occur postoperatively is that of hypercapnic respiratory failure. And this is quite common in this patient population, in particular because of pump failure. So your respiratory pump is both your respiratory muscles, and again, in patients with neurologic disorders or neuromuscular disease specifically, they very often have reduced neuromuscular strength. And they can have things like scoliosis, which impairs the mechanics of breathing significantly. Additionally, especially over time, they may develop decreased ventilatory drive, and this may be even more prominent in patients with some of the complex neurologic disorders, some of our epileptic encephalopathies, bad cerebral palsy, things like that. In addition to the pump failure, very often in this circumstance of anesthesia, we'll have increased respiratory load. And so patients with neuromuscular disease often have things like rigid chest wall tone or really floppy chest wall tone, leading to respiratory dysfunction. They can develop retained secretions and atelectasis, or again, just with some of their pulmonary or chest wall underdevelopment, there can be both frank atelectasis and microatelectasis, leading to increased resistance and increased respiratory load in the system. In addition to hypercapnic respiratory failure, these patients very often will have impaired secretion clearance. So, in terms of your central airways, the major thing that will be used to clear your secretions is that of a cough. And a cough has three major phases: the inspiratory phase, a compressive phase against a closed glottis, and an expiratory phase. And in patients with neuromuscular weakness, very often that they don't have the strength for a strong inspiratory phase, nor an expiratory phase, and depending on the condition, there may be bulbar weakness as well, leading to a failure of that compressive phase. Additionally, in some patients, those with bulbar weakness or complex neurologic disorders may have chronic aspiration or microaspiration that can contribute to bronchiectasis and can impair kind of airway clearance from the peripheral airways as it affects the mucociliary clearance, which is involved in clearing secretions from those smaller airways. So when we're talking about the post-operative respiratory complications in this population, often it starts with atelectasis and pneumonia. Again, you have these retained secretions, you have neuromuscular weakness, you're not able to maintain those airways open. And this progresses to your acute respiratory failure, which may be both hypercapnic, secondary to pump failure and increased load with this atelectasis, as well as hypoxemic with secretion retention, contributing to VQ mismatch. As this progresses, you may have failure of extubation and need to reintubate, and even tracheostomy. And this is really what we're trying to avoid. So we're talking about then a high-risk population. Primarily, we're talking about neuromuscular disease. As I've said already, pump failure is common in these patients. They have respiratory muscle weakness, and with their chest wall deformity, scoliosis, they're often at a mechanical disadvantage when breathing, so they're already weak and now at this mechanical disadvantage. Additionally, they have this increased respiratory load. Chest wall hypotonia may drop the functional residual capacity below the closing volumes, and you end up with areas of microatelectasis and increased load. And then the ineffective cough leads to an inability to clear secretions and then predisposes atelectasis, pneumonia, and hypoxemic respiratory failure. Additionally, if bulbar weakness is present, you may get aspiration. These patients are also at high risk because often their work of breathing or their respiratory failure is noted late, given they're not generally able to develop significant increased work of breathing outside of tachypnea, so it's easy to miss or be recognized late. Other populations are simply the scoliosis and chest wall deformity patients. Again, it's not uncommon for patients with scoliosis repairs to undergo prolonged periods of mechanical ventilation, and rarely even intubation. Risk tends to be at its highest with FVCs less than 60% in the neuromuscular population, and in the non-neuromuscular population, it's certainly seen when FVC drops below 35% or 40%. Additionally, patients with cerebral palsy have many factors which can contribute to their high risk. They have scoliosis, they have chest wall deformity, they have impaired cough strength and cough reflex at times. So maybe they have a nice strong cough, but they're happy to have retained secretions indwelling for long periods of time before they cough. They may have a longstanding history of aspiration and aerodigestive disease, which leads to bronchiectasis. And then they can have both sleep apnea, obstructive sleep apnea, hypoventilation, as well as upper airway obstruction during wakefulness. And the neurodevelopmental or the neurodegenerative population is very heterogeneous, but a lot of those problems that we've spoken about already are present in this population. So how do you assess risk in your patient? Well, that's going to be multifactorial, and we'll go through that. So, the first thing that you have at your disposal is a history. in patients that have cerebral palsy, especially if they're GMS-CF5 or the complex neurologic disorders, you may not be able to do more objective testing, or objective testing may be more complicated. So a reliance on history is important. Are these patients who have recurrent respiratory admissions? And if so, are they severe? Are they being admitted to the ICU and needing respiratory support? There's good evidence that viral illnesses decrease muscle strength and vital capacity. So if these patients catch simple viruses and are being admitted in a recurrent fashion, they're less likely to tolerate the surgery and anesthesia and the associated risks. And then obviously you can look at previous postoperative courses. We know that pain, sedation will impair kind of respiratory muscle strength. And so if there's a history of prolonged ventilation or extubation failure with surgery, that's going to be a red flag that this is a high-risk patient. Additionally, on history, you can look at, have they been on respiratory technology previously? Are they currently on non-invasive ventilation or bi-level PAP? I'm going to be using those terms interchangeably here. Or are they using technology to assist with coughing? So that could be mechanical cough assist or mechanical insufflation, exsufflation, or maybe other assisted coughing like bag mask recruitment with manual assisted cough. Those should be red flags that, again, these are patients that you probably want to be aware of and very careful when you're doing your pre and post-operative planning. Do they have symptoms of hypoventilation at baseline? Do they have morning headaches or grogginess? Is their basal saturations less than 95? And are there additional procedural risks that we need to consider? We know scoliosis surgery, for example, is very high risk. Is there malnutrition present? That's going to predispose increased risk in our patients. Moving on to more objective testing, the best test we probably have in a patient capable of doing it is that of forced vital capacity, which is performed using spirometry. So there's lots of studies in the neuromuscular population suggesting there's increased risk once your FVC is less than 60% predicted. And certainly when it's less than 30% predicted, we know patients are at much higher risk. One study looking at adolescents found that the most sensitive marker for respiratory failure around viral illnesses was when their inspiratory capacity dropped below 1.1 liters per minute. But obviously this can't be extrapolated to younger children where that number is probably less important or impactful. Another objective test we have is that of peak cough flow. So this is almost like a peak flow meter, except you have the patient breathe in and cough into the meter. With a peak cough flow less than 160 liters per minute in, again, adults and adolescents, we know those patients are highly predisposed to extubation failure. And then other guidelines are using a cutoff of 270 per minute in the neuromuscular disease population, with the idea being that, we know that when they are sick or when they undergo anesthesia, their baseline peak cough flow is going to drop. And so if it's, once you're at 270 liters per minute and you're over 12 years of age, once you have these complicating factors, surgery or illness, you're at much higher risk of moving towards extubation failure. You can assess daytime gas exchange. So that's looking at things like diurnal hypoventilation. So if your CO2 is over 50 millimeters per mercury, this is a high-risk patient. They're already hypoventilating and they haven't undergone these taxing procedures or illness. So this can be assessed using a capillary blood gas, end-tidal CO2, or transcutaneous testing. And then another suggestion that there may be issues with gas exchange, again, is a low basal SpO2. So if your basal stats are less than 92%, this may be indicative of hypoventilation and or retained secretions, both of which are predisposing high risk for our patient. Finally, assessment of sleep disordered breathing may be warranted. So this could be looking for obstructive sleep apnea, central sleep apnea, or nocturnal hypoventilation. Our gold standard test for this would obviously be polysomnogram. However, this isn't available everywhere and may be not tolerated by a number of children. So occasionally we need to use oximetry and CO2 monitoring to try to get a sense of, is this patient higher risk? So again, oximetry, there are a number of studies and there's no gold standard in terms of what to look at, but we thought probably an SpO2 of less than 88% for 5 consecutive minutes or less than 90% for 10% of the total sleep time are indicators of significant hypoventilation potentially, but these are often late findings. So again, if you're having an early nocturnal hypoventilation, this may be suggested by just a low basal sat kind of less than 95 or 94%. And if you're just kind of trying to analyze the progression of disordered breathing in patients with neuromuscular disease, this is a good diagram that, again, shows your dysfunctional breathing and your impaired gas exchange first will start in sleep and in REM. It will progress to involve non-REM and then eventually progresses to daytime hypercapnia. And so this is where, once you're there, you're high risk. And that's why assessing daytime gas exchange is useful to really identify those very high risk patients. And then you will see the box here, which again indicates that any kind of chest infection or anesthesia puts the patient at even higher risk. So how do we mitigate risk in our patient? Well, this is where the prehabilitation comes in. So you want to think about mitigating risk early. You want to do it in a multidisciplinary fashion. So this is obviously going to involve yourselves, anesthesia, surgery, but also hopefully a respirologist or pulmonologist and some kind of RT or physiotherapist with expertise in BiPAP, airway clearance, such as mechanical ventilation, and very often will rely on technology. So who are our high-risk patients? Well, when you look at Duchenne muscular dystrophy guidelines, they recommend the use of preoperative non-invasive ventilation once your FVC drops below 50%, and basically describe it as necessary or needs to be utilized once FVC drops below 30%. When you're talking about mechanical insufflation, exsufflation, or mechanical cough assist, again, it's that magic number of less than 230 liters per minute when your patient is greater than 12 years of age. Otherwise, you may need to rely on history and asking parents, are you getting these recurrent respiratory illnesses or pneumonia with predisposing viral illnesses, or is the cough especially weak and non-productive? The spinal muscle atrophy guidelines are a lot more, don't give you specific numbers, but just say preoperative non-invasive ventilation or BiPAP, and an MIE are warranted when there's respiratory function becomes abnormal or when there are abnormal sleep studies. And really, we've had to extrapolate these guidelines to the other populations we've involved here. So why are we doing preoperative NIV and mechanical cough assist? Why can't we just do it in the postoperative phase? Well, there was a good study that employed neuromuscular protocols for extubation and actually found that previous users of these technologies were more likely to have successful extubations and less likely to fail. So why are these patients more likely to succeed? Well, starting it early and before surgery, allows them to develop skill with the technology, comfort and tolerance at home. It also allows you to gradually titrate pressures up to therapeutic pressures, which may not be tolerated acutely the first time you're wearing the device. And so you want to get there slowly. It also means they're more likely to come in with appropriate settings and with an appropriate interface. You get to troubleshoot that stuff in advance of needing it. And finally, even though there are protocols, we know that if a patient comes in and is already using non-invasive ventilation, it's more likely the ICU or anesthesia is likely to extubate them and put them right on their non-invasive ventilation. How you start non-invasive ventilation and mechanical cough assist is probably beyond this talk, but hopefully you have a respirologist or pulmonologist who can do that and is comfortable doing it. And it really can be done in hospital, in the sleep lab, in the clinic, or at home, depending on your resources and expertise. For mechanical cough assist, again, often you want to start low and go slow. So often we're starting at subtherapeutic pressures of plus or minus 15 centimeters of water and gradually trying to build up to therapeutic pressures of plus or minus 40. If mechanical cough assist isn't available, you can always try to employ other airway clearance techniques such as lung volume recruitment using bag and mask, and then manually assisted coughing. So other preoperative management may include management of bronchiectasis with 1 to 2 weeks of antibiotics. This is in those patients probably less often neuromuscular and more often things like cerebral palsy, epileptic encephalopathy, where there's been aspiration and aerodigestive disease leading to bronchiectasis, and you may increase chest physiotherapy, whether that's percussion or whatever's being employed. And obviously, whenever possible, you want to optimize nutrition. Again, intraoperative considerations, you just want to think about the ventilation strategy. Should it be invasive versus non-invasive? And can we prevent atelectasis? So that involves adequate PEEP. And, if it's not required, probably not using things like 100% oxygen. Again, you want to think about medication and sedation in terms of can we minimize respiratory depression and still keep this patient obviously safe and comfortable. And then there may be disease-specific considerations. And finally, our post-operative plan to prevent complications. So really, you want to develop this plan preoperatively. Neuromuscular extubation protocols typically involve an assessment of readiness. So you want normal SATs and room air, normal CO2, a baseline chest radiograph, minimum suction requirements. When all of these are present, you probably feel good that you can extubate, and you're going to extubate right to BiPAP. And they talk about high span pressures, so a large delta P, to eliminate kind of risks of hypercapnia. And you want aggressive airway clearance with cough assist, suction, things like that. And what's really important is, again, you don't want a spontaneous breathing trial or an excessive weaning of pressures, because that tires the patient out and leads to atelectasis and microatelectasis, which makes it harder to succeed when you're extubating the patient. So really, our goal is to extubate the patient when they're fully recruited and well rested. This protocol comes from largely this paper by Bach et al., which has been cited many, many times, but basically they took 157 consecutive unweanable patients, so patients that ICUs were not willing to extubate, including 83 for whom tracheostomy had already been recommended. And they showed that actually, despite this population that is very high risk, where people are saying they need tracheostomies, their first attempt at extubation success was 95%. And of the 8 failures, 6 of the 8 they were able to extubate in the future. So, in conclusion, patients with neuromuscular weakness, complex neurologic disorders, these predispose respiratory complications, but with careful assessment of them preoperatively, and in select patients, starting BiPAP or non-invasive ventilation, initiating aggressive airway clearance even in advance, and making sure you have a good plan for extubation, you can have successful procedures and successful extubations, even in very high-risk patients with very poor pulmonary function. Thank you very much, and I'm happy to answer any questions.
Okay, thank you very much for such an enlightening talk, Dr. Aaron, and we are glad that you've managed to join us, even though it's very early your side. Okay.
Thank you.
Right. Before we actually go to the Q&A section, perhaps, we could actually just go through the poll questions that we had run right at the start of our webinar. And we'll get each of our panelists to actually go through the questions and also to give us the correct answer. So, Tanuja, would you like to start off first?
Sure. Okay, so maybe we'll get that slide up. Rolling fast. Okay, so it says here, repeated instructions by different people is beneficial to a child or individual with special needs. Now, is this true or false? So I think at the start we had a very close tie. If I remember the breakdown, it was like 49% saying true and 51% saying false. So in this case, I would given the context, especially in a healthcare setting, it would actually be false. Okay. So let me just give a quick explanation as to why. Again, when we look at kids and also individuals with special needs, there's lots of triggers and there's lots of things happening around them. So sometimes they need time to process. So when we keep repeating the instructions and we have different people saying it, different tones, different ways of saying it, that can also contribute to an overload of information for the child or the individual. So we would always say just to have that concept of having one person usually speaking to the child, giving the directions, and then also giving a bit of time for the child to actually process, or the individual rather, to also process and understand what is expected of him or her. Okay, thank you.
Okay, thank you very much, Tanuja. Okay, and the next question, I think it's mine. Okay, so first and foremost, I'd like to kind of apologize because I think the pre-recorded talk actually came out a little bit muffled, but I do hope that people actually managed to at least read the slides to get an idea of basically what I was talking about. For this particular poll question, we had actually asked our audience to choose the best correct answer. And if I remember correctly, actually, the majority of people actually chose C, the use of guided imagery. The correct answer is actually B. Okay, and we'll just go through it one by one. So I think hopefully by the end of the talk, people will kind of realize that actually with the help of social stories and sufficient preparation, and in particular, okay, if it's actually a severity level 1 child, then a child with autism does not always actually require pre-medication with anxiolytics, okay? Although those with the more severe levels of autism, yes, they may require pre-medication, but even so, I did try to share in my talk that even with nonverbal, moderate to severe children with autism, with sufficient preparation with the mask, they actually take the mask even without pre-medication and know what to do with it. So in which case, it's very easy. You just turn on the gas once they've actually applied the mask themselves to their faces. Okay, secondly, let's go through C. The use of guided imagery is not helpful, and this was specifically brought up basically because children with autism actually have limited capacity for imagination. So they do much better if you give them clear, direct instructions. Okay, so the last option, children with autism have a high threshold of pain and therefore do not need analgesics. That is not quite true as well. Okay, we do need to treat in accordance. It doesn't necessarily mean that all children with autism have a high threshold of pain and therefore do not require analgesics. Put it this way, the noxious stimulus is going to be there. How they perceive this noxious stimulus may be variably interpreted by the individual as pain severity. However, we should still give analgesia if we anticipate that this procedure is painful. Okay, so the correct option that was suggested was actually B. A nonverbal autistic kid cannot understand what is said. Okay, in many instances, even if the child is unable to express themselves, they can actually follow instructions. So it is important to be able to suss out then appropriately whether even if a child is nonverbal, the child can actually follow instructions and understand what you are saying. So I hope this basically will have answered your queries as to why the correct answer in this instance is B. Thank you.
Hopefully everyone can hear me. Which of the following patients is at the highest risk of extubation failure was my question, and I did give you obviously a number of patients who are high risk. And I think, you know, the correct answer that I have here is C. And really the reason for this gets into some of that peak cough flow. So once they start reaching over 12 years of age, in patients with neuromuscular weakness, really, there were quite a few studies that showed a peak cough flow less than 160 liters per minute, almost universally fail extubation in the absence of airway clearance techniques. So whether that's your mechanical insufflation, exflation, or manually assisted cough, and this came again, I think it was a different paper by Bach et al., but really there seemed to be almost this line where there are patients who had peak cough flows at the time of extubation over 160. Almost all of them had successful extubations even without this technology, or could get there. Those with less really needed additional technology to get there. You know, otherwise, you know, your low FVCs are certainly a concern. A peak cough of 300 liters per minute is good, and even during illness we expect it to remain over that 160 liters per minute for the majority. And you know, obviously having OSA is a bit of a risk, and low FVC, but probably not, doesn't portend the same risk as, again, this peak cough flow less than 160.
Thank you. Okay, shall we move on to Dr. Roshali? Would you like to unmute yourself, Dr. Roshali?
Thank you so much for that prompt. Yes, the question we are dealing with is microaspiration a concern for children with cerebral palsy? I know there are the answers differ from each other just a wee bit, especially A and C. Let's ponder and dwell into it. This is as follows. First, yes, it's a real possibility, and it indeed is. I guess the poll really answered in that fashion. No, not at all. That's incorrect. There is always a possibility. So we come to the third one. it is a possibility, but it's not 100%. Definitely those who have a gastric reflux, which is in fact mirrored into their night awakening or a bit of retching, these are the ones who would always have a real possibility, and almost you should assume that they would aspirate and take it up in that manner. This is what my thoughts were while I formulated this question.
Okay, thank you very much. Okay, so now it's time for Q&A, which Dr. Linda will facilitate.
So now let's have the first question. I think the first question, Tanuja decided to answer this live. The question is the father's relationship associated with anxiety in children undergoing surgery?
Okay,
Okay,
thanks.
Tanuja?
Thank you, Dr. Linda. And I think thank you, Nabila, from Indonesia for this question. That's a really nice question. And it's interesting to note, actually, it's not the father or the mother in general. I would say it can be any adult. Okay, so we wouldn't necessarily zoom it in to say it's the father that's causing the anxiety. It depends on how this caregiver, the adult or the parent, presents himself or herself. So if this caregiver is not very familiar with the way the child communicates, with what the child is comfortable with, then that caregiver who's going in to support the child may not be the most effective person to do so. So it could be the mother, it could be the aunt, it could be the father. So it's not necessarily just the father. We would say that anyone who's supporting the child, be it either of the parent or a caregiver, needs to be familiar with what helps the child to tick in the positive sense. So we would say that he or she needs to be calm, because if the parent or the adult is himself or herself very anxious and very stressed, then their communication to the child is going to also be impeded upon. So that's not very useful. So you need someone that's calm and in control. And this parent or adult needs to be able to have done some preparation with the child and in a way that makes sense to the child. So sometimes talking might help, but if this parent is more intuitive, then maybe using the visual cues or social stories that might be more effective. So as long as this adult is someone that's familiar to the child, familiar with how the child communicates, someone that actually brings comfort and the child and knows how to read the cues of the child, I think then that would be the most appropriate person to go in, regardless of whether it's the father, the mother, or anyone else. I hope that answers your question. Thank you.
Okay, thank you very much, Tanuja. All right.
May I? Evange?
Yeah.
Yes, Tanuja, I do get your point. I am just trying to look at this question from Nabila's point of view. Nabila, you have specifically said father. So what did you think, and you have asked us this question? Do you think fathers stay a little emotionally aloof, or is it something like that you are trying to point out, which may not be the truth, however, but still, since you did mention father so specifically? And of course, Tanuja has made it clear. Anyway, we could go ahead. If at all she means something else, then she would type.
Yeah, I think so. Okay, but Rosalie, I think that's a question for you. I think this is basically from Aldo, and basically Aldo is basically asking how does chronic spasticity in patients with cerebral palsy influence the choice of post-operative muscle relaxants and their reversal?
Well, what we mean by postoperative muscle relaxants are not the relaxants that we use. We're talking about central muscle relaxants, which could be a dose of tenazidine or baclofen, and that probably is something that they would be under even before we take them up for surgery. I hope I've answered your question.
I wonder though that perhaps it's also taken in the context of maybe intraoperative rather than postoperative muscle relaxation. So, maybe you could just answer if it were intraoperative, okay, and muscle relaxation is required, what would then be an appropriate choice of muscle relaxation?
Okay, the appropriate choice in my practice, at least, is always atracurium. However, I have seen that they need a wee bit of more dose. There is no scientific study for me to say that, but this is my personal experience.
Okay, thank you very much. And perhaps, okay, if a train of four monitoring is actually available, that possibly can actually be used to actually guide the dose of a neuromuscle relaxant that actually needs to be used. But thank you very much for answering the question. Okay, Erlinda.
There's another question on the Q&A box that asks how do you deal with disruptive parents or relatives or overly protective parents? I think that's for you, Tanuja.
I wish there was a one size fits all, and I wish there was a miracle answer to this. But I would say, again, as professionals, it's also the way that we provide information to them, and also how do we convey that we have the child's best interests at heart. Sometimes parents, especially those with children with special needs, they are very protective over their child, and rightfully so. They may have had some unpleasant experiences of, healthcare workers just brushing off their concerns and not listening, not really paying attention to their child. So they come in with all this baggage. So I think from the get-go, it's really important to assure them that what exactly are you here for? What are you going to do? How are you going to support their child? What kind of tools do you have in place? This communicates to them some confidence. It also gives them that assurance, and also getting them to partner with you. So, right, I think for all of us, we've always said that, be upfront to say, hey, let's partner together. You are your child's best advocate. I am not standing here to take that position, but these are some of the things we can suggest. What do you think? So I think have that collaboration and open communication going. And when you are authentic and you are sincere, that gets communicated, and it actually just brings down that defenses in them. I hope that helps to answer your question.
I guess that's right. It's really a matter of perception. It's really 50% for each partner in the care of the child, right? Okay, now I have a question for Evange. Evange, you mentioned something about restraints in your talk. Well, are you talking about physical restraints or pharmacologic restraints?
Right. Okay. So I think both. I think the use of restraints, even in the neurotypical children, is actually applied in certain instances as well. Okay, if there is basically at risk of things like cannulas falling out or drains falling out, etc. But the restraint that we're actually talking about when we talk about a pre-op part, it may talk about physical restraint. Okay, for example, in the process of induction, if they're actually not going to be cooperative. But we will also touch on pre-medication or anxiolysis or sedation, okay, preoperatively, which basically can be considered a form of pharmacological restraint, right? And getting the caregiver to actually help us come to an agreed decision on how, if we're going to try this, and if this doesn't work, right, the child is still agitated, what do we actually do next, right? I think the preference always is that if there's actually going to be physical restraint as well, perhaps, okay, engage with the caregiver ahead of time to kind of figure out what might be the most appropriate way to actually hold the child, so it feels more reassuring to the child rather than have 5 or 6 people jump on the child, right, in order for you to complete your anesthetic induction. That by itself could be very traumatic, I would actually imagine. Yeah. I hope that kind of answers the question.
Yeah, thank you for that. I really had to know what kind of restraints, because that's always a question when you talk about children, especially if you have their parents or relatives with them. So you have, again, like Tanu just said, you really have to partner, collaborate, explain the whole plan, right? Do you have any more questions, Evange?
Yeah, I do think so. I think there's been quite a lot of interest in Dr. Aaron's talk on prehabilitation. A few questions have actually popped up in the Q&A section, right? So we do have one question, for example, on how do we actually prevent atelectasis? Would you like to?
And I think. Oh.
Yeah.
And hopefully by the end, a lot of that was covered. But I think there, there are strategies you're going to employ preoperatively. I think even getting them on BiPAP and on mechanical insufflation, exsufflation, or introducing kind of the low tech, if that's what you need to do, bag mask recruitment, and then manually assisted cough. When you clear the secretions, that'll lead to them hopefully not being as atelectatic when they come to you in the OR, and then being on NIV regularly will help to recruit them and have them kind of fully ready. But intraoperatively, you want to make sure you're using adequate PEEP. You may consider longer TIs and things like that if you've developed atelectasis, hoping to re-recruit. And then again, you have that big post-op. Hopefully you can save the slides, but the extubation protocol afterwards, which is again how you make sure that you're extubating them in a fashion where hopefully you have as little atelectasis as possible and they're as compliant as possible.
Right. Thank you very much. And I think there were some questions also about prehabilitation, in that the non-invasive ventilation, how long ahead of time does it actually need to be applied for it actually to be effective? And my added question to that basically is, how fast can you actually escalate in terms of the pressure that's actually used?
Yeah, and I think that's, again, it really has to be individualized, and you probably need to think about how severe the surgery is and what the risks are. And unfortunately, there's no one-size-fits-all solution. But if it's, we have some patients that we admit and have up to therapeutic settings within, 2 or 3 days, which can be done. Hopefully I hear about this months in advance, and then I just am slowly working on it, and they gain more and more comfort gradually over time. And that's my preference where it's there. My surgeons will say, oh, this kid's probably headed for scoliosis surgery, and I see their FVC is 28%. Hopefully by that point in time I've actually already started NIV, and usually I have most of the time. But oh, this is a kid with a low FVC that's high risk. They're planning it in 3 or 4 months, and it's like, okay, I found out from the surgeons it's happening, so that by the time they come to you, hopefully you don't even really need to think about it. It's already there.
Right. I do have to say that, in the interaction with some of these children who have actually been placed on such ventilation strategies, there's been some resistance actually with compliance with the use of these, ventilation. So do you have any tips, or how do you actually get them to actually comply, right? Knowing that it can actually make a difference to the post-operative course.
And is it coming from the parents or the patient? Just
the patients, yeah.
Yeah, I mean, this is a real struggle, and it's a real struggle with this population, because I think it's very, very scary. A lot of them know that it's coming, but don't want to believe that it's coming. And also the changes happen so gradually over time, they get used to living how they are. I mean, for me, I feel like the biggest advantage I have is I get involved with these patients really early. I warn them this is coming, and I build trust. In the short term, I mean, I think I don't know that I have a specific good strategy. Otherwise, other than, hopefully trying to be just as honest with them as possible, and really letting them know that, like, there is a potential that this avoids some of those risks after surgery, like a breathing tube or something like that, or tracheostomy. And really, this is the surgery you need. Yeah. We're trying to optimize you for success afterwards.
Right. Yeah, thank you. And also, they did put up the extubation criteria down there. I'm just wondering if it may not always be practical to actually do a chest X-ray, for example, or a table to kind of make sure, that the chest X-ray looks normal before you actually extubate. Are we then saying then that all these patients should actually be sent to the ICU intubator and make sure all the points of the extubation criteria are met before we take the tube out?
And I think the answer is probably not. It's all a question of risk. That neuromuscular protocol came for patients that were intubated because of respiratory failure, so not necessarily specifically anesthesia. So these were patients who, it was from a chapter on the acute management of respiratory failure in these neuromuscular patients. So yes, if you've been ventilating them, they've been very compliant on your on your operating table and you have no specific concerns, I think, especially it might be different, again, if their FVC is like 25%, but if this is a patient with an FVC of 50%, they've done very well, you're extubating them right to BiPAP. You don't necessarily need to get your chest x-ray in the operating room or anything like that.
Okay, great. Thank you very much. Okay, Dr. Rushali, would you like to take these questions? I think Karina basically asked, how do we pre-medicate uncooperative, anxious patients with neurologic or muscular disorders for surgery?
Muscular disorders.
Yeah.
You're muted.
Yeah, unmuted. Thanks for the prompt again. Let's take one by one. Say, for example, if we go towards autism, and the speaker has very clearly said the role of desensitization and, of course, the role of primary caretaker. We need to pre-medicate them. It could be that the mother who is at home or whosoever is the primary caretaker, especially in an autistic child, might just mimic, say, putting nasal drops. It could be normal saline at home so that the child doesn't get overwhelmed and it doesn't come as a shock when something of this kind is done, because the child has gotten over that sensory stimulus as such. I always feel that if the primary caretaker is the person who knows the child very well, he or she is the correct person to give a pre-medication rather than the personnel the healthcare personnel who may not be that well acquainted. Having said that, these children do come to us again and again, and if we have a team and it's the same anesthesiologist, it is going to be the litmus test of that anesthesiologist. If the anesthesiologist is very well versed and does get acquainted with the family and the child, and there is a smile, and then you go ahead and pre-medicate. I know it's not going to be a very smooth interaction, but it would be an easier interaction. This is how I would take this question.
Thank you very much. And you have another question, actually. How do you reduce complications from anesthesia for cerebral palsy? Particularly, I think, patients with uterine retention and pneumonia.
Yes, most of the cerebral palsy, especially those with crouch, especially those who are severely wheelchair bound, they are the ones who come for longer surgeries, repeated surgeries. It could be soft tissue releases, it could be multi-level soft tissue releases and multi-level osteotomies as well. So I guess optimization in the preoperative period is the key. Also, it does not really happen all the time. It's not that we see them going out with the tube in the PICUs very often. However, it's good to share this with the patients in the preoperative period. Second is, we can definitely prevent it by, as I said, optimization, physiotherapy, continue with bronchodilators if need be, pick them up in a time zone where they are at their best, assume that they're going to have basal atelectasis, assume that they will not be able to give you correct PFTs because of their disability itself. So this is, answer is optimize, answer is give them good pain control so that there is no shortness of breath, at least due to intense pain. So give a good regional block, and yes, nebulize them before shifting to the OT is again a difficult task, but can be done. So this is how you would treat by preventing and take care of pain management and see to it that the PICU is kept ready.
Thank you for that answer, Vishali. I have one last question, if that's okay. Dr. Aaron, you mentioned the use of technology for such cases, and I'd like to know, how do you think advancements in technology like telehealth or wearable devices can be utilized to enhance rehabilitation? Would this be useful for them?
I think that's a good question. When you're talking about wearable devices, you're talking about for monitoring specifically?
Yes, maybe
I
for
mean, it's certainly something
monitoring.
you could probably try to employ maybe to get a better sense of, you know, at least in the neuromuscular disease population specifically, if that's what we're talking about, you know, if you can get something for monitoring home sats or something along those lines, it may help you get a sense earlier when your patient's hitting something like therapeutic pressures. Or you could see maybe sleep quality change or things like that. So it may be something we could, I guess, employ in the future to help us get it, you know, determine are we hitting those thresholds we need to be at in terms of rehabilitation, in terms of being on technology that we're ready to proceed or that we're on therapeutic pressures. And certainly we can get regular downloads actually on patients that are starting on BiPAP to help answer a lot of those questions. It's beyond the scope of this, but determining are you on therapeutic pressures or not. Actually, the BiPAP itself can often be attached to a modem. You can get a download and you can have the family kind of auto titrate from home with your guidance based on kind of the parameters you're trying to reach.
Okay, thank you for that. Any more, Evanch?
No, I think very good. I think we've actually answered all the questions actually that have been put up.
Yes. So really, the webinar underscored the significance of individualized care, right? And interdisciplinary collaboration based on all the talks. That's what all of you said. So by implementing these tailored strategies and engaging families and putting all together, we can really enhance patient comfort, safety, and overall outcomes in the preoperative and postoperative period. So we'd really like to thank all our speakers today. Thank you very much for being with us today. So to end this, your certificate of attendance will be automatically generated and forwarded to those who submitted the post-webinar survey. Now, the webinar survey will be emailed tomorrow, February 17th at 1700 hours, Singapore time. But please ensure that you actually have correctly keyed in your full name and your email address. Please don't forget to visit, like, and follow us on the website of the Asian Society of Pediatric Anesthesiologists, Facebook, and YouTube. ASPA, again, is a nonprofit organization, and its mission is to foster the highest standard of pediatric anesthesia care in Asia. Hence, we seek your help to donate and help us in our cause. Just scan the QR code. And soon enough, we will be having the annual conference of the Society of Anesthesiologists of Nepal, together with the 21st meeting of the Asian Society of Pediatric Anesthesiologists on April 4 to 5 at the Hyatt Regency at Kathmandu, Nepal. And of course, last but not least, not the last, sorry. The next ASPA-FLEX webinar is a near-infrared spectroscopy in congenital heart surgery, which is organized by the ASPA Cardiac Special Interest Group on March 16, 2025 at 5:00 p.m. Singapore time. And you are also invited to the World Congress of Anesthesiologists at Marrakesh, Morocco on April 15 to 19, 2026. So thank you, everyone. Thank you to our speakers. Thank you to our moderators, of course, our technical team. Thank you and goodbye.